All right, thank you again. We also have no disclosures for this presentation. So in 2015, our center described a novel, minimally invasive approach to transversus abdominis release. In our early experience, we utilized traditional transabdominal lateral port positioning, but as we gained experience, we recognized how challenging it was to suture defects closed with lateral ports. The enhanced view, totally extraperitoneal approach was previously described for laparoscopic inguinal hernia repair by Dr. Jorge Dejes in 2012. And this provides direct access to the retromuscular space with a more flexible port positioning. We would apply these same principles to ventral and incisional hernia repairs, and this is just a quick video of us gaining access into the retromuscular space. As you can see, we've marked out the salient anatomy, linea alba and linea semilunaris bilaterally. We put a balloon dissecting trocar in, and we blow up the space to give us our working room. And as you can see here, we know we're in the right plane because we can see the rectus abdominis muscles above, and we see the white posterior layer below. And from here, we can start our dissection. This is one other video where the surgeon is standing on the patient's right side, and as you can see in the small diagram on the bottom right, trocar number 3 is where our camera is. Trocars 1 and 2 are the surgeon's working instruments, and here we are backhanding closure of a upper midline defect in diastasis using an O barbed suture. We then lay mesh into this retromuscular space in typical Reeve-Stopa fashion. In our early experience, we were using fibrin glue to seal the mesh and releasing pneumoperitoneum. So, the aim of our, actually before I move on, to see more videos and to kind of get a better idea of the description of these steps, feel free to come to Dr. Igor Belyansky's talk this afternoon at 4:30. So the aim of this presentation really was just to describe our early operative outcomes and quality of life utilizing the eTEP access technique for complex ventral and incisional hernia repair. This was a retrospective review of laparoscopic retromuscular hernia repair cases from 5 centers on 4 different continents over a 1-year period. And we just want to give a shout out to all the centers that helped us. We had 2 centers in North America, our center at Anne Arundel Medical Center, and Dr. Yuri Novitsky's group in Cleveland, Ohio. We had Dr. Jorge Dejes from Colombia, South America, and we also had a center in Bucharest, Romania, Dr. Victor Radu, as well as Calcutta, India, Dr. Ramana. So we'd like to thank them for their contribution. So our primary outcomes, we looked at demographics, hernia characteristics, operative details, and post-operative complications. We used the Carolinas Comfort Scale for our quality of life. I assume most of you are familiar with the Carolinas Comfort Scale, but this is a scale that looks at 3 symptoms: mesh sensation, activity limitations, and pain. There are 8 questions, and previous studies have found that a score of 2 or higher is significant in terms of being symptomatic. So when we look at our demographics, we had 79 patients in this group. They were obese patients with a high percentage of patients that had prior ventral and incisional hernia repairs. The rest of the demographics are listed here below. Our perioperative data was significant for mean defect area size of at a mean of 13 by 10. We were able to place very large mesh, upwards of 30 by 30, in the retromuscular space. And we really were able to move away from transfascial fixation for the majority of our patients, where 75% of our patients, we utilized fibrin glue to seal the mesh. In terms of our intraoperative complications, we did have 1 conversion to an open procedure in a patient that had a history of multiple small bowel resections in the past. And there was 1 conversion to an IPOM technique in a patient who had a rupture of their linea semilunaris when there was aggressive overinsufflation with our balloon. In terms of our post-operative complications, we did see 2 seromas. One of those resolved on its own with just conservative management. The other one required an interventional radiology place drain. We did have 1 dehiscence of a trocar site that just required local wound care. We saw no non-wound related complications within 30 days in this group. We also had no reoperations or hernia recurrences in our mean follow-up of 107 days. When we looked at our quality of life, using the Carolinas Comfort Scale, we did find that we had 58% of patients that complained of pain preoperatively. We had 46% of patients that complained of movement limitations. We looked at their scores at 1 month, and we found that the pain had decreased to 23%, which is about a 60% decrease, and movement limitations had decreased to nearly 16%. At 6 months, we saw a more dramatic decrease, with 18% of patients complaining of pain and only 6% having movement limitations. And to evaluate our quality of life, we used the same methodology that my senior author and Dr. Colavita used in 2012 in an Annals in Surgery paper that looked at laparoscopic and open ventral hernia repairs. And within their laparoscopic group, they saw very similar rates of preoperative pain. And at 1 month, they really didn't see any difference in their pain. And we attribute that to the fact that a lot of these patients were performed in the traditional laparoscopic ventral hernia repair methodology. And with our cohort, like I said, we have moved away from penetrating fixation, which we think has kind of explained some of this decrease in early postoperative pain. And at 6 months, they did have a 25% decrease in pain in their study. So in conclusions for our study, we demonstrate here feasibility, safety, and effectiveness of this access technique, even when performed for complex cases. The eTEP access approach offers a totally extraperitoneal suture closure of defects, wide mesh placement with minimal fixation, and a flexible port setup. Thank you very much.